Greetings of health and wellness, and welcome to Health Futures Foundation Incorporated's free webinar is Long COVID Real. Are you ready to learn more about long COVID as well as post-COVID conditions and how to manage them? Ngayong pong araw, yan po ang ating pag-uusapan. And I am Nurse Natalie, and I will be your facilitator for this webinar. And of course, we have this afternoon, we have a lot of people joining us today who are diagnosed with long COVID, probable long COVID patients, and of course, family members of a long COVID patient and health professionals. And from the bottom of our hearts, nagpapasalamat po kami na kayo po ay nandito ngayon, not just on our Zoom room, but of course, we are seen live on Facebook. And of course, spending your Friday afternoon with us. So magandang hapon po. Magandang tanghali sa inyong lahat. And we are glad to have all of you here this afternoon. And before we start, I would like to remind everyone to utilize the Q&A, our Zoom Q&A feature for questions. For those who are inside our Zoom room, ang ating Q&A ay bukas na po if you have advanced questions or maybe different questions to our speakers. Just make sure to address ang inyo pong question per speaker. And selected questions will be addressed during our open forum. Use the chat box for your comments. And lastly, we value your feedback. So please accomplish, meron po tayong evaluation form to be accomplished within 24 hours after the webinar. And upon submission of the evaluation form, you will get a raffle entry and a chance to win a surprise prize from HFI. And of course, e-certificates will also be provided to Zoom attendees who will stay throughout the program and accomplish the short evaluation form, which will be sent towards the end of the program. So maraming salamat po sa inyong lahat. And without further ado, I'd like to call on Dr. Jaime Galvez Tan, the Chairman of Health Futures Foundation Incorporated, to give the welcoming remarks. Doc Jimmy.
Yes, thank you so much, Natalie. And thank you for joining us and being our host. A warm and pleasant good afternoon to all. I would like to extend my heartfelt thanks to all the participants and our resource speakers who are joining us today. HFI welcomes everyone to its webinar entitled Is Long COVID Real? According to the World Health Organization, the emergence of long COVID among COVID-19 patients represent a global public health emergency as it continues to affect thousands of people worldwide. And in the Philippines, medical experts are starting to look at the long COVID syndrome and forecast its long-term impact on individuals who have been diagnosed with COVID. HFI advocates to have initiatives on establishing long COVID support groups in the Philippines, and I hope that this seminar will stimulate the creation of such support groups. I would like to especially thank Dr. Camilo Roa, Dr. Veeda, Michelle Anlacan, Dr. Rontgene Solante, our resource persons, for graciously sharing their expertise that will surely be helpful to many. I also especially thank my wife, Bex, for sharing her long COVID journey. I pray that God's faithfulness to sustain her the past year will encourage and inspire those who are going through the same experience. May you be enriched with what you will learn today. God bless you all. Thank you.
Thank you so much, Dr. Jaime Galvez Tan, for your opening remarks. And a very informative speech. And to start off the discussion about long COVID, ito po ang inaabangan, lalo na po yung mga nasa room ngayon, and also to our live stream viewers. Our first speaker is Ma'am Bex M. Galvez Tan, who is celebrating her first year long COVID anniversary in another 2 weeks. She is one of the founders of HFI and presently its executive director. And she has dedicated 45 years of her nursing professional life to providing marginalized communities access to primary care services, improving their health literacy, and advocating for health promotion and prevention. To share more about her long COVID story, let us hear it from our first speaker, Ma'am Maria Rebecca Galvez Tan. Ma'am?
Good noon, everyone. Today, I celebrate 1 year since I got infected with COVID-19. In 2 weeks, it will be my 1 year of long COVID. 2 months ago, I celebrated my 69th birthday. This birthday in 2022 was most meaningful because it had been an uphill climb to reach this glorious age. Stricken with critical COVID last year, I wasn't sure if I would even see the light of all these celebrations of life today. While I might have survived critical COVID, long COVID deprived me of life in many ways and robbed me of many of the pleasures and things I used to enjoy. The post-COVID long-term effects test your mettle with so many changes in the body, loss of functions, and a myriad of limitations. Sometimes you wonder whether the pell-mell of symptoms will ever end. This is my long COVID story. On November 3 last year, COVID-19 managed to sneak peek into our household and I got infected. It was initially mild COVID, fever, some cough, and body aches for 3 days. And after that, some malaise and occasional cough. The HRCT chest and the COVID panel markers were okay, so I was on home care. On day 10, however, my oxygen saturation started dipping to the low 90s. I was brought to the hospital where I was informed I had severe COVID. Several days after, I was told 3/4 of my lungs were collapsing and intubation was indicated. With the grace of God, the unceasing prayers of family, friends, and their friends, the competent management of my medical team and nursing team, I survived critical COVID. Despite my idiopathic anaphylaxis, multiple adverse reaction to drugs, and the refusal to be intubated. After 21 days, I was finally discharged. Though worn and weak, my spirits were high then, excitedly looking forward to being on my own after some rest. Unfortunately, I was to discover that aside from damaging a great portion of my lungs, COVID ravaged my body, leaving it deconditioned and debilitated. My respiratory rate was at an average of 40 per minute. The normal is about 20. My heart rate was almost over 100 per minute at rest, even so when I move a little. I could not turn to the side on my own. Even with assistance, it was a major production and quite a challenge. It would take me at least 5 minutes to be able to turn to my side. Bawat kibo, hingal na hingal. I felt so drained every time I moved, even if I was on 4 LPM of oxygen. The mere act of eating was a challenge. Before I can take a spoonful of anything, I had to do at least 5 deep breaths until I reached 95% of oxygen saturation. 1 spoonful, 5 deep breaths. Less than 95% oxygen saturation, I get no food. I could not brush my teeth or do oral care because my oxygen saturation dips. I had difficulty swallowing, and I keep on burping and burping, very loud and deep burps that it could be heard in the other room. I was dependent on assistance even in movements inside the bed. I could not pull myself up the bed without any aid. I could not tolerate high back rest. So I was under full care, fed, bathed, and the whole works in bed. I was even in diapers. I felt so much like a baby. On the second month, I started my cardiopulmonary rehab. My first exercises were close open, like the baby, and ankle pumps. I had to relearn many things that I used to take for granted. How to eat, how to talk, pull myself up to sit, do long sitting, turn to the side, get out of bed, stand and walk, among others. Reconditioning the body entailed going through a regimen that can be initially tormenting. One day you feel so well, on other days it can just be so disheartening. You take 4 steps forward, the next time it will be 6 steps backward. To divert me from everything I was feeling and going through, I went back to work part-time. On my third month, whereas before talking literally took my breath away, I can chat now for a while without being breathless. From phrases, I have graduated to sentences and even paragraphs. Thanks to aggressive cardiopulmonary rehab, my respiratory rate was now at 20 per minute and my heart rate at 68. I'm still on oxygen support, but on low levels now. I could do breathing on room air, successful at most to 2 hours at rest lying down and 40 minutes while seated. I can get out of bed on my own. I have moved from a walker to a cane to walking unassisted. I'm able to go downstairs to the garden for a short time and back to my room. I can walk slowly about 140 meters on minimum oxygen support. I recall, though, how much effort it took me just to sit up, how much I was gasping for air when I first dangled my feet in bed. I recall the triumphant feeling of the first time my feet touched the floor after almost 2 months, probably much like how Neil Armstrong would feel when he first set foot on the moon. I recall also how my legs seemed as heavy as hollow blocks when I first started to walk. I could not lift them up. I could not bring my legs higher than 6 inches off the floor while walking. Getting on the stepper was one big heavy chore for me. Standing on one leg was almost impossible to do at first. Initially, I walked like a robot because I could not bend my knees. When I finally got to bend my knees, I walked like I was always drunk because of problems with balance. However, at month 3, I was more independent, more coordinated, and more aware of myself and my surroundings. In a way, I was also toilet trained already. No more diapers since I'm able to go to the toilet now. It was a liberating feeling after 90 days. However, I would desat whenever I wash my face. The rehab doctor told me that there are so many muscles actually involved in washing the face, so more oxygen is needed. But in time, I would be able to do so. I was also shocked to find out I was not even strong enough to open the fridge door. I also had chest pains and breathlessness while walking, even if my O2 sat was 96%. How could this be? Could I be imagining things? It was quite disturbing for me that what I feel does not jibe with the oximeter reading. I actually felt quite weird and abnormal. I had a cardiac clearance and my heart was good. Then a doctor friend told me that there might be actually micro damages caused by COVID and that no instruments so far are sensitive enough to pick these micro damages. On the fifth month post-COVID, my heart was briefly filled with sadness. While I can breathe on room air much longer, I was still on 1 liter per minute of oxygen support for many of my activities. Second, there was the horror of seeing my hair fall in big clumps while I was sleeping, walking, taking a bath, or just by merely touching my head. It's just the hair, people say, but I guess it was more of losing another part of me because of COVID that made it distressing. My infectious doctor said it would grow back, and it did after 2 months or so, thanks to a high protein diet. I started to have weekly episodes of anaphylactic reactions on my fifth month, even to food and products I have been usually taking and using. Anaphylaxis is a severe allergic reaction that can be life-threatening. In my case, I have no rashes or any external manifestation, but my airway just closes, so I am unable to breathe. For the good news, I am able to walk without O2 support for 90 meters. Sitting, I can breathe on room air without oxygen support for 6 hours. I'm able to play ping pong for 10 minutes, although not with the form and speed of the Chinese champions. On a good day, I can play 2 sets of ping pong. I can do a rally and my balls don't fly that high anymore. I can do 3 hours of physical therapy 3 times a week with 2 kilogram weights, 3-pound dumbbells, stationary bike with some resistance, and the works. I can now wash my face without my O2 sat dipping. With 6 meters of O2 tubing put together, I can do more activities of daily living. Get my own food from the fridge, clean up my table, take a full bath, prepare my breakfast, dress myself, do makeup, put on my sneakers, tend and water some of my plants. I can now tolerate 15 minutes of standing and moving around without O2 support. With that, I managed to walk 452 meters, or 1/4 of the UP Academic Oval, with 3 15-minute walks, 2 stops, and 2 oxygen refills. Probably chicken feed for the healthy and the robust, but for me, it was a wow moment. Several weeks later, I was able to walk around the whole 2.2-kilometer UP Oval. It took me an hour and a half with 7 oxygen refill pit stops. It was a double wow moment. Ironically, while I feel much better, being patient has become a challenge. There are so many things I want to do but cannot because of the limitations posed by my compromised lung function. I have learned, though, that 1% is better than 0%. Moments of envy for those who had fully recuperated earlier from COVID come and I go. And I ask, why can't I be like them? What more do I have to do? What am I doing wrong? I found gratitude to be a panacea for times like this. To get out of the well of frustration, I had to pinch myself to be reminded of the blessings and the new milestones in my recovery and be joyful for each one of them. My daughter often reminds me how fresh from hospital discharge I can only do close open with my hands and ankle pumps in bed. How on Christmas Eve I couldn't even sit up in bed by myself or turn to the side. Whenever I am tempted to compare, God reminds me how unique I am and that each one has a different Calvary to bear. After 7 months of being cooped in, I felt my head was shrinking, so I went out of my cave for the first time for an out-of-town trip for some vitamin C and a good dose of vitamin D. I was told I could actually take a dip in either the beach or the pool, but the Habagat waves were too much for me. So I got in the pool instead and did a few frog kicks and my rehab exercise regimen with my oxygen. While I got so tired after this trip, I had an overload of shots of happiness and serotonin to boost my sagging energy and morale. Month 7 saw my downhill. From the high of having circumnavigated the 2.2 kilometers of the UP Oval, suddenly I couldn't walk any more than 20 steps without going breathless and dipping oxygen saturation. I also started having frequent sore throats and chest congestion. My RT-PCR was always negative though. My exercise endurance has decreased. My PT activities have been downgraded to stretching, chair yoga activities, passive and assistive exercises. No more weights and no more long walks. Even after what seems to be very simple tasks like washing 2 plates, watering a few indoor plants, or taking a bath, I have to contend with crashes, episodes of very severe body cramps, pronounced fatigue and breathlessness that could last for days. The scourge of fatigue also whips my body when I am unable to pace my activities. The fatigue is so pronounced I can hardly get up, with every millimeter of my body throbbing and aching beyond what I can imagine, every joule of energy zapped. I also noticed my heart rate going over 100 when I stand up and move around now. I am blessed with more good days than bad days now. The good days, though, can give birth to bad days. On good days, I forget that I still have limitations and I become too bibo doing a lot of things. I end up in a crash. Pacing and the art of slow mode is a new word in my vocabulary I am trying to master. Living with the post-COVID syndrome entails traversing through a long meandering road strewn with rocks and boulders of pain, frustration, and exasperation. Long COVID for me is tantamount to Calvary. It is a heavy cross that I carry inch by inch in my journey to the pinnacle of full recovery. Each day is a tussle. The suffering and uncertainty of the end of this long COVID is like a knife that pierces the heart again and again. The changes, the challenges in long COVID are overwhelming. It can feel insurmountable at times and too much for the human spirit. Walking with God, the loving support of family, friends, my prayer warriors, the guidance of my health team have sustained me through the havoc brought by long COVID. I couldn't have done it alone. In moments when my human strength is at its ebb, remembering that the Lord is faithful and sovereign has kept me going and hopeful instead of falling into and wallowing in the pit of self-pity. Surrender to His divine plan has made it easier to walk in His pace, regardless how protracted it can seem to be. The trek out of the woods is at a snail pace. The light at the end of the tunnel seems brighter. I do not know how near or far I am from it. Right now, 3/4 of my lungs are good. I have not had any brain fog. My emotional barometer is okay. I am functional, though with limitations, and I can work. But like the snail, I know I will get to the end of this journey. I have learned to celebrate simple joys and laugh and be content with a new me and the seemingly mundane things I am able to accomplish. I rejoice in every little thing I am able to do rather than whine for those I can no longer do. I have cried a river and grieved over the loss of my old me. Moving forward, I'm slowly embracing my new normal. Not too many Vivo moments, my nasal cannula, oximeter, and oxygenator twinning with me. No more speedy, very driven, workaholic me. No adventures for the meantime. No superpowers. I realized I cannot be Darna anymore. Kasi nakuha na ni COVID ang bato. I have been given a new lease on life. Whatever the limiting circumstances now due to long COVID, I feel that this life given back to me is still a gift to cherish, nurture, grow, find meaning in, and live to the fullest. I choose to thrive rather than merely survive. Finally, my heart is hopeful that from this sunset in my life, one day there will come my divine sunrise. So, is long COVID real? Totoo ba ang long COVID? My answer, long COVID is real, totoong totoo, at hindi lang inarte ang long COVID. Salamat po.
Thank you so much, Nurse Rebecca Galvez Tan, for that very informative, no? From the first month up to the last and celebrating in 2 weeks, her first year of long COVID. And thank you so much once again. If you have questions for our participant right now, nakita ko 120 in our room, but right now it's going up to 200 plus. And if you are tuned in on our Facebook Live, hello. Ayan, pwede rin po kayong mag-iwan ng inyo pong questions on the comment section. And let us proceed to our next speaker. We have the privilege to having Dr. Rontgene Solante as one of our resource speakers. Dr. Solante is an infectious disease specialist and a prominent consultant on COVID-19 in the Philippines. And Dr. Solante is also an assistant clinical professor of the Department of Medicine at the University of the East, Ramon Magsaysay Memorial Medical Center. And as an infectious disease expert, Dr. Solante is currently the chairperson of the Adult Infectious Disease and Tropical Medicine Fellowship Program at San Lazaro Hospital and a section of the Infectious Disease Committee on Infection Control at the Medical Center Manila. Dr. Solante is also known for being the physician in charge of the first 2 confirmed cases of COVID-19 in the Philippines and was one of the infectious disease experts invited by the former President Rodrigo Duterte to discuss the COVID-19 concerns in the Philippines. Today, he will discuss the long COVID and its aftermath to help us understand the long COVID syndrome. If we have Dr. Rontgene Solante. Doc, good afternoon.
Hi, Natalie. Good afternoon. I'll just have to share my slides. Okay. Can you see my slides?
Very clear, Doc.
Yeah, thank you, Natalie, for that long introduction. But first of all, I would like to thank also Dr. Roa for being instrumental in inviting me to share my points here on long COVID. And this is really something that a lot of us should really be aware of. So these are the scope of my discussion. So we'll speak about the overview now of the current data on COVID-19. And more specifically, what led to this long COVID? What are the specific pathomechanism? Why does these patients with long COVID, just like Mom Bex have, will lead to these long-term complications? And what are the other important organs that are also involved with long COVID? And we'll also touch on approach to management. So this is the latest from the WHO as of the 26th of October, the weekly epidemiological data. It seemed that for the past 3 to 4 weeks, there is a consistent decrease in the number of COVID cases. And part of that also is more important that the death rate also has significantly decreased. No? But we're not yet off the pandemic. It seemed that the pandemic we are only in this situation that cases are going down and more or less the mortality is going down. But the other end of these COVID cases is also the complications. And mind you, we haven't seen this type of complications for a long period of time, any viral infections. I haven't had experience before with SARS-CoV-1. We don't have that. MERS-CoV-1, we don't have that. Even influenza, we don't have long COVID. And this is why some of the experts are really perplexed. What is the mechanism and how did this turn out into a complication that lasts not only for weeks, but even months? So if you look at this particular diagram, it shows here that when you have a patient with COVID during the acute phase of the infection, it usually lasts for around 3 weeks, especially for those who have severe COVID. And if you notice, this is the red one, this is the level of the virus. And it seems that the viral, the level of the virus only stays more or less in our body for the most is 3 weeks. But if you are immunocompromised, like in our experience here in San Lazaro Hospital, where we have HIV positive patients, we have patients wherein the RT-PCR is positive for even up to 4 months with a low, with a high viral load. But these are exceptions. So in general, the virus stays only like 2 to 3 weeks. But what causes these symptoms to persist even after the acute infection? So this will only show you, we also have what we call the post-acute COVID symptoms. And this is what we call the long COVID. So there were initial definitions of this during the initial part of the pandemic. There was one who said it is long COVID, which means that there are presence of symptoms weeks or months after acquiring the infection. There are those who defined it as a post-COVID syndrome, so which means that illness extending 3 weeks after the onset of symptoms and even persist more than 12 weeks. And there are those who said it's a combination. It's either a post-COVID or a long COVID, as long as the same clinical manifestation, you have persistence of symptoms, irrespective of the underlying mechanism, can be as high as 35% among those who had acute infection to as low as 10%. So these are just some of the estimates during the first year of the COVID. In 2021, October, because of the persistent report of these complications, it has been institutionalized and being considered already as a condition. And they call this the post-COVID condition or the long COVID. So WHO made a clinical criteria when to consider long COVID. So of course, you have been diagnosed with SARS-CoV-2 infection and the presence of symptoms, persistent symptoms within 3 months from the onset of the symptoms when you have the acute COVID, which can last for at least 2 months. And number 4, should not be explained by any alternative diagnosis. So there are no other diagnoses that can explain the symptoms. So these are the different common symptoms. Now, how frequent is long COVID? So there are now new data to tell us because of a lot of studies, a lot of institutions, countries focusing on this because of the alarming number of people who have been affected with long COVID, not just because of the morbidity that is associated with the symptoms, but there are also higher risks of mortality as a part of the complications of long COVID. So it varies from 5 to even as high as 60%. There are those who reported this that it can affect 1 in every 3 infected patients. So it may be an overestimate, but you can see the propensity that this is something that's really disturbing. It doesn't only affect adults. In fact, children can also be affected with an incidence rate of 1% to 27%. And that is why we always indicate that protecting children is as important protecting the adult, especially for people who are qualified for vaccination. And we have to really emphasize that. Now, during the first few months of the pandemic, it seemed that most of our patients who had been admitted in the hospital, who developed more severe form of COVID, are the ones that have the higher risk of long COVID. But as the pandemic evolved and we are seeing much milder cases of COVID, especially during the part of the 2020, later part of 2021 and early part of 2022, we did not expect that even in patients with only mild and even don't have symptoms, they were just only RT-PCR positive. And after 3 months or 2 months, they manifest some of the symptoms of a long COVID. So which means that regardless if you are asymptomatic, if you have mild manifestations of COVID, everyone is at risk of developing long COVID. And what is important now is that why we try to look at it as something that can be prevented and can be reduced. And one of that is with the use of your vaccination. And there are also data now that will tell us that if you give also the antiviral agents in the mild to moderate cases, then there's a higher chance that you can also prevent long COVID. So it can be classified as short COVID wherein after the acute symptoms, it will last for at least 3 weeks. If it will last more than 3 weeks, that's post-acute. And then if it will last more than 3 weeks, up to 12 weeks, then this is called a chronic COVID. So what's really the mechanism of long COVID? These are some of the theories by which most experts believe that it always starts with the acute infection. When you have an acute infection during the viral phase, your body, okay, will also react and produce anti-inflammatory agents. Okay? But these anti-inflammatory agents are not what we call the usual infection that it can be easily controlled. There is also an aberrant increase in the number of your pro-inflammatory agents. And this is why you have the inflammatory phase of the infection, where most patients will develop more severe form of symptoms. In fact, this is what we call the cytokine storm. So more inflammation, more symptoms, then this is where most patients will also have a higher risk of long COVID. In some patients that have recovered, okay, the effect of the different abnormalities brought about by the inflammatory phase can also be an important aspect why long COVID can be a complication. So this is what we call a multifactorial mechanism of that contributed to long COVID, and not only related with the virus, but also with inflammation and also the host factors, which means that there are specific host factors that are higher risk of developing long COVID. Now, in some of these initial published publications, it seemed that it involves a lot of different symptoms, okay? And majority of this report indicated that a patient with post-COVID usually have more than one symptoms, okay? Can be in the range of patients presenting with fatigue, okay? Difficulty of breathing, persistent cough, and then some have neuropsychiatric sequelae like anxiety, depression, difficulty in sleeping. And then during the initial part of the pandemic, especially during 2020, one of the more common sequelae is also the loss of taste and smell. So for those who had manifestations of this, it can be prolonged. It can be recovery is also longer, and that is one of the most common, more common presentations of long COVID during that time. So there are those who documented that they also have diarrhea, they have hair loss, okay, skin rashes, and in fact, what I would like to highlight here and our other speakers can also highlight this one, is the neuropsychiatric derangement. Okay, and one of the more common observation among those who reported post-COVID symptoms, and this is the data coming from clinicians from the US, is brain fog or cognitive impairment. There are those who reported also of difficulty of sleeping, impairment of the daily function and mobility, mood changes, and there are also women who have abnormalities in their menstrual cycles. Okay. So I'll go through each of the different complications and how this led to a long COVID. Okay. One is the pulmonary complication. Although Dr. Roa will discuss this later, but I will just have to give you a generalized concept. What is the mechanism of pulmonary complications? The main mechanism here is still the effect of the virus and the effect of the immune response to the virus. Okay, so which means that the presence of the virus and how our immune response to the virus will be also affecting how our lungs will accommodate and adapt, and eventually will have some long-term damage. Okay, and based on clinical experience in some of our patients, especially for those with chronic lung conditions like tuberculosis, like COPD, you can also see some of the effect of COVID in the form of fibrotic changes. And that's why manifestations like difficulty of breathing is really common after recovery, decreased exercise tolerance, as what Ma'am Becky is experiencing now, and they have this test to determine if there is also decreased exercise tolerance. The 6-minute walking distance was lower, and in some patients, unfortunately, in some patients, we have difficulty of weaning them. Okay, what about the cardiovascular complications? What is the effect on our heart? Okay, so it seemed that the most vulnerable part of the heart is the muscles of the heart. We call this the myocardium and the cardiomyocyte. And this is where direct toxicity of the virus that is related with these complications in the form of myocarditis. So you have some inflammation, you have immunologic response, just like what happened when you have pulmonary complications. And that's why it can lead to myocardial fibrosis or scarring. At the same time, you also have some dysfunction of the ability of your heart to function because of the effect of the cytokine storm. And what have you as a complications? Some patients will have cardiac arrhythmias even after recovery. Some will have persistently elevated blood pressure. Okay. And some will have complaint of palpitations, difficulty of breathing, chest on and off chest pain. And worst among this is that they can also have higher risk of myocarditis and myocardial injury. So we're talking here of myocarditis and myocardial injury after an acute infection. So these are not during the acute infection, these are after the infection. Then we also have some effect on these neuropsychiatric complications. So I will not touch on this because one of our speakers will focus on this. Endocrine complications. We've seen some of the patients that are not diabetic before, but after COVID infection, 2 to 3 months after, found out that they have already irregularities in their sugars. Okay. In some patients with diabetes, they have difficulty also in controlling their sugar level, even with optimum intake of their medications. Okay. Renal complication may not be as common as that with pulmonary and cardiovascular complications. Why? Because renal complication is an indirect damage caused by how the heart will also be damaged or the lungs will be damaged. So there are patients that will, after recovery, will develop increase in creatinine, persistent increase in the creatinine due to acute tubular necrosis, so damage in the tubules of the kidney. and some of them really require dialysis. Okay. On the gastrointestinal and hepatobiliary part, may not be as common also as the pulmonary and cardiovascular. There are patients who complained of irritable bowel syndrome in the form of on and off diarrhea, usually early morning, that cannot be explained by any other mechanism. There are those who also complained of dyspepsia, so which means parang hyperacidity. No? So these are just some of the observations on how this can affect the gastrointestinal tract. Because remember, your gastrointestinal tract is also an organ where you have most of this ACE2 receptor. Remember, the ACE2 receptor is the receptor by which the virus will also bind. So in a way, the effect of the inflammation during the acute infection can also give you some residual damage to the gastrointestinal epithelium, leading to these manifestations of irritable bowel syndrome and dyspepsia. Now, the most other important sequelae may not be as common as the cardiovascular and pulmonary, is the hematologic sequelae. And in fact, there was this new data now, which was published 2 weeks ago, that among those who had a stroke, okay, 3 to 6 months after COVID, 3 to 6 months after having the acute infection, have stroke. So they look at patients with stroke now, and one of the important aspects is that you have to look into if they have previous COVID. Why? Because with previous COVID, there was a strong association that when they develop stroke, this is also part of a long COVID manifestation due to the thromboembolic events. No? Although it may be less in this particular data as of 2021, but in that latest data, I think it can be as high as 10 to 15% can lead to stroke. So remember, when you are hypertensive, when you are diabetic, you're also higher risk of stroke if you don't take care of your blood pressure. But again, these are patients that are not hypertensive, okay, and only develop stroke without any other reason. And this is why we need to look at it as probably a complication of a COVID because of the thromboembolic events. Why does patients with COVID, post-COVID, will develop stroke? It's basically because of what we call thromboinflammation and a hypercoagulable state. So I would like to show you here an updated global data on individuals who complain with persistent cognitive and respiratory symptoms. Okay, so these are reports coming from 22 countries. No? So this is really a big study wherein they pulled 54 studies, and then around 1.2 million individuals are included in the study. So the data collection was done in March 2020 to January 2022. And what was the result here is that 6.2% of the individuals, so that's 1.2 million, 6.2% of that, have at least experienced at least one of the 3 long COVID symptoms. And here's the catch here in this particular data. Among those COVID individuals who were hospitalized, long COVID duration was 9 months, okay? And among those who were not hospitalized, so meaning they only have mild to moderate COVID, the duration of long COVID was an average of 4 months. So this is how they look at it, no? The more severe, the longer the clinical manifestation during the acute symptom, then probably you have the longer duration also of your long COVID. If you only have mild symptoms or even asymptomatic, then you also have less number of months in terms of the duration of your long COVID. So what are their findings in terms of symptom description? If you look at the respiratory problem, they clustered it into mild, moderate, and severe. So here, it is mild if the cough and shortness of breath only exists after heavy physical activity. But if the symptoms of cough, shortness of breath, and wheezing will occur even after a light physical activity, or only walking in a short distance, then that is considered moderate symptoms. It is severe if the cough, wheezing, and shortness of breath, or even difficulty in walking, or will occur at rest. No? So that's already severe. The most common cognitive problem is really remembering recent events. So hindi na recall yung pinaka recent na events, no? And they find it hard to concentrate and make decisions and plans. So this is why some of these patients cannot really go back to their usual work, okay, because of these cognitive problems. So it's mild. If it is moderate, meaning you have memory problems, confusion, there is disorientation. Sometimes patients will hear voices, okay, that are not real, and they need help with some daily activities. For those patients who also have persistent fatigue, they always felt tired and easily upset, feel pain all over the body, and in fact, some of them have depression. Now, what is very important in this study is that even younger individuals, as young as less than 20 years old, also have long COVID. Okay, but for unknown reasons, when they compared the symptom cluster between male and female, it seemed that female have a higher symptom cluster compared to male, and this they cannot explain why. No? So it means that more affected are the females compared to male. Then there are also in this data that in some patients, 43.1 within 3 months after the symptom onset of a long COVID needed an ICU care. And it is more common among those who are females. Okay. You see here that even after 12 months, 20% still will need an ICU care. So this is something that we just can't neglect, because there's a possibility that these people can really go into severe form of clinical manifestations. The effect of a long COVID can still be persistent and can still cause a lot of this mortality. And in fact, in one data that I was able to collect, that if there's a possibility that this patient will be readmitted, higher risk of readmission, there's also a higher risk that they will die during their readmission. Okay, and the most common cause of death is pneumonia or a respiratory disease. Okay, so that's why in some countries now, if a patient with long COVID is discharged from the hospital and they are at risk of a respiratory infection like pneumonia and flu, they should also be given pneumococcal and flu vaccine. No? So that's part of their protocol to prevent the complications of this infection that will also trigger higher risk of severe pneumonia. So how does management will now be for long-term long COVID? Now, this is the perspective of primary care, so which means primary care will be an important part in the management of long COVID. And referral for a tertiary care will only be important when there are findings that in the primary care that entail a long-term complications that need specialties, okay, like pulmonologists and cardiologists. So these are some of the important medical management. But I emphasize here listening and empathy. It's important, no? Because we thought that at times we thought that this long COVID is just something, an ordinary symptom. It's not, okay? So when you have people or patients or relatives having the symptoms, you have to listen, you have to empathize, you have to really understand them, no? Hindi lang to basta-basta na effect ng COVID, okay? Now for the self-management, they encourage here like limiting coffee intake, limiting alcohol. If you're a smoker, you have to quit smoking, you have to have adequate sleep, and then you have to also manage your diet, okay? So this is an interdisciplinary management, which means that from cardiovascular, pulmonary, to renal, to endocrine, and that's why it's important that This management support should be integrated in one particular centers. No? So there should be a particular center. So all centers or medical centers should have this capability to manage a long COVID. And these are just, I'll be showing you some of the important clinical features that really warrant immediate evaluation. No? So from cardiovascular to pulmonary, you have also dermatologic here, patient having alopecia, okay, psychiatric, and then hematologic. The rest are also very important. Okay, so it's a comprehensive. Patient needs a comprehensive rehabilitation plan, holistic support, and of course symptom management approaches. No, why? Because there's no treatment yet for long COVID. The treatment is really more on a comprehensive approach, and part of that is symptomatic management. Like, for example, if you have muscle pain, you give pain reliever. If you have on and off fever, you can give paracetamol. But more or less, it may not totally clear the symptoms, but at least it can alleviate some of these symptoms. So these are some of my conclusion. It's important we healthcare professionals should be able to recognize. Okay, then we have to document, investigate, and more importantly, we have to follow up and identify specific complications, organ-specific complications, particularly if it involves hematologic, pulmonary, and cardiovascular. It is also very crucial for healthcare system and hospitals to recognize the need to establish dedicated COVID-19 clinics. So as I've mentioned, provide integrated care, prioritize those at high risk for acute, post-acute COVID-19. So meaning if you have COVID acute infection, it's important that you have to follow up with your doctor to identify if you have long COVID symptoms. So I think it's important that this is not just an ordinary long COVID complication. It should be part of the national priority. If we prioritize vaccines and antiviral therapeutics, then there should also be priority in managing patients with long COVID. Okay, and I would like to end with my talk by looking at this. This was published just November 3, consensus to end the COVID-19 public health threat. And part of this is prioritizing the treatment of severe COVID-19. And we're doing that now, with the antiviral agents, the monoclonal antibody, and also prioritizing also the treatment of long COVID and the overall burden of disease. So it's now part of the management in terms of treatment and care, that long COVID is really something that we have to deal with. So as we move on with this pandemic, we continue to encourage everyone to get the vaccine because of the risk that protecting you, getting the infection will also be important in protecting you in getting a long COVID. If you have COVID and you are in the high-risk group of population, there are very good antiviral agents, and there are data to tell us that with antiviral agents, you shorten the risk of the symptoms and prevent progression to severe COVID, although we don't know yet if it also will prevent long COVID. With that, thank you very much for your kind attention.
Thank you so much, Dr. Rontgene Solante. And that is a good discussion. It's a very unique complication of the COVID-19 that, according to Dr. Rontgene Solante, is hindi naging present, from his experience with MERS-CoV, even with SARS-CoV-2, and of course, different nga po yung lumalabas na complication. But the best advice coming from our doctors is you still have to get the vaccine. Thank you so much, Dr. Rontgene. Our next speaker, we also have Dr. Camilo Roa Jr., a respiratory medicine specialist, as one of our resource speakers. And Dr. Roa is an internationally recognized expert in the field of respiratory medicine for leading the pioneering and translational research on tuberculosis that investigated the outpatient supervised short course chemotherapy, and the discovery of Pulmo-1 mechanical ambubagger. In terms of COVID-19 initiatives, Dr. Roa co-developed a low-cost and high-quality portable ventilator for COVID-19. And he has also pioneered the establishment of the first community isolation centers for mild and asymptomatic COVID-19 patients. He was also one of the principal investigators on COVID-19 vaccine trials in the Philippines, and Dr. Roa was also recently awarded as the new National Academy of Science and Technology, or NAST academician. For this webinar, we will discuss post-COVID lung problems and management. Ladies and gentlemen, everyone, our next speaker, Dr. Camilo Roa Jr. Doc?
Yes, thank you very much, Natalie, for that kind introduction. And can I see if I can present my slide myself? Yeah, so I'll see. Just tell me if it does not show again. Is it coming? Okay, Natalie, can you see it?
Right now, we're waiting for it to appear on the screen, but it's indicated, Doc, that you already started screen sharing.
Okay, maybe there's a problem. My screening it. It's the same thing. Can you now just flash my slide? I will stop share. Okay. Well, my slide is coming out. Yeah, that one, and just put it on slideshow. Okay. So, Jean, thank you very much for that very comprehensive review and very up to date. And I guess everyone here will benefit that context of your presentation and the context of the symptoms of Manbeck. What I'll do now is to dive to the pulmonary part of the problem, and actually you mentioned some of the mechanisms that will be discussed. So can we have the next slide? Okay, and next slide. I have no particular conflict of interest in this subject matter. Next slide. Okay, so in discussing the implication, the diagnostic as well as the treatment of long COVID, I would, next slide, sequentially present to you, next slide, the common respiratory manifestations, and that was actually alluded to by Jean. Can you go back? Yeah, the acute injury and the residual effects of COVID on the lungs, because part of the symptoms would really be from the injury and the residual, say, fibrosis that happens in the lung. How this came about, and I will like to give you a parallel on what Dr. Solante told us, that the mechanism happening also in other organs. The clinical course of the pulmonary defects in long COVID, specific and long-term treatment of this condition, and a question, maybe we can answer it in the open forum. Can pulmonary long COVID be prevented, or even long COVID affecting the other organ systems? Next slide. So if you go by the surveys, and this was also mentioned by Dr. Jean, the study, next slide, the next please. You see that respiratory manifestations are common in long COVID. You saw how Manbeck actually narrated her problem, and that she's still on oxygen once in a while. And I just remember that this is described by this guy from CNN who had mild COVID actually. Richard was not confined, but he suffered for months. He called long COVID. At that time, there was still no term for long COVID, but COVID-19, a tornado with a long tail. So that's how he described it. How appropriate it was. Next slide. And the reason why the pulmonary system is heavily impacted is because it's the usual entry area of the virus. The virus is inhaled, and then it deposits in the upper airway, and then it manages to go down the lower airway, and as it goes there, it gets into the cell via the receptors, the ACE2 receptors mentioned by Dr. Solante earlier. And where the virus is, with the intention of just multiplying, it does not really intend to kill people. Okay, then there will be manifestations. And it just so happened that if that localization is in the lungs, then you really affect so many things. As mentioned earlier, the localization can be in other organ systems where the ACE2 receptor is present. Okay, but let's follow the respiratory. Next slide. And we follow this longitudinally from the start of the illness with the imaging, CT scan, and then we have in the graphs below the different biochemical parameters. Okay, and then let's have the first picture. So when the person gets COVID, okay, and the first thing that happens in the patient is the appearance of some whitening in the periphery where the arrows are. Okay, very mild, and the rest of the lung is spared. And in fact, the ordinary chest X-ray, this cannot be seen most of the time because the ordinary chest X-ray is not that sensitive. Okay, next. Now, as the days progress, next, in a person who is in a way susceptible, look, the areas of involvement have increased, and now you have a more white or intense infiltration, meaning the lung is more involved. Next, and here in the third picture you have as you can see barely enough lung to use for breathing. The breathing lung is the black area. And if you correlate it below, you look at the red line. The red line is the viremia, the amount of virus in the blood. But as you can see, it's actually happening when the virus levels are actually going down. Next. And this will continue even when the virus in the circulation has continued to go down. And in fact, next slide. What has increased next is actually the evidence of increasing inflammation, the inflammatory markers. In the blood, we have several of these markers. We do monitor this when the patient is in and see how it correlates with damage of the lung. So it's not just the virus, but the additional effect of inflammation and immunologic stimulation. Next. As days pass, okay, some repair actually occur. And when there is a continuing inflammation and repair, then you have a lot of fibrous material, fibers, actually that are deposited, scars in layman's term, deposited in the areas involved. And the scars, they are thicker and not really normal tissue in this lung or in the airways. And that can be a source of problem because for the longest time, we think of scars as something permanent. I have good news, though, that in COVID, the occurrence of the scar does not necessarily mean that it will be there forever. There is a natural tendency of improvement. Unfortunately, not all will have clearance of all their scars. Next slide. So if we look at the mechanism of injury, and this was explained by Dr. Jean, you have three mechanisms, A, B, and C. Okay, in A, you have the direct effect of the virus on the cell. If you look at the figure on the left side, so where the virus attacks, gets inside, in the desire to multiply, the cell actually can suffer. Let's go back. Can suffer, and the cell will die. But in addition to that, look at B. B is when the inflammatory response comes in because of the host trying to defend itself with the release of chemokines, cytokines, and actually now affecting a bigger area than what the virus just infected, resulting into more deaths. And sometimes, as alluded to by Dr. Jim, you have actually more pathophysiologic changes here, more hypoxemia, and the patient can die. And then C is when there is perpetuation of this mechanism. Instead of a short-term situation happening and then it goes away, we have acute immunologic recruitment of the cells that can produce more cytokines, and all this conspire to a situation where you have a runaway case now, even after the virus levels have gone down. Okay, next. Let's look at some examples in the lung. If you can make out the airway in the picture there, the upper part of the airway that goes to the, I'm sorry, my pointer cannot work because I'm not the one projecting. The normal airways are usually smooth, but here below you have parang bako-bako, you have dilatation of some areas, parang lubak, bronchiectasis. Okay, now the traditional view is bronchiectasis is a terminal event and you cannot do anything. And that's really a worrisome statement because when people are in the hospital and gets discharged, chances are in the majority, 2/3 will have bronchiectasis. But if you look at the figures in the table there, you see that among those with bronchiectasis, actually 75% the bronchiectasis will disappear, meaning this is not the usual bronchiectasis. Some will actually get better. But 1/4 of those who did develop will have persistent bronchiectasis. Next slide. So we look at this, next slide, please. Series of CT scans of a 62-year-old with adult respiratory distress syndrome, very bad case of COVID pneumonia. And see in the 7th day of the illness, there's already in the arrow bronchiectasis. Okay, and day 19, you have worsening of the situation. But look, about the 4th month, the bronchiectasis actually disappeared. Okay, so that's very good. Next slide. Unfortunately, it doesn't happen to all. Sana all, but unfortunately, we have this case shown here, behaving like this, the other cases, where the bronchiectasis was detected on the 24th day and 30th day. That's more than a month. And look, from the 5th to almost the 6th month, you still have bronchiectasis as a residual. And with that present, you can have persistent symptoms like coughing, okay, and in some cases, some breathlessness if the bronchiectasis is very bad. Next slide. So that's in the airway. Now, the rest of the lung, where the airway and then you have the alveoli, okay, there will be swelling with the virus there, okay, the acute swelling. But after a while, there could be fibrosis, as shown in the graphics earlier. Here, if you look at C, the one with the green and the orange are fibrotic lung, not bronchiectasis, but the lung itself will be hard now to expand. Okay, and this is this occurrence correlates with high inflammatory markers like ESR, CRP, LDH, and severe pneumonia on imaging. So the worse the condition, you have also repair that happens, and the effect of the repair, the laying down of fibrous tissue, shown there in green and orange, will also be very bad. Okay, next slide. However, if we follow the fibrosis, the scar happening in the alveolar sacs, okay, from discharge, okay, you can see the in the column there, a figure, towards the first, third, and 6 months, there is a improvement. So of majority actually, but it's not all like that. There will be some persistence. Next slide. And so how do we treat that or actually prevent that? Maybe we can again discuss this later, but Dr. Jin told us that we now have interventions that have been shown to make the acute COVID less severe, and maybe that will work. Of course, there are interventions that will prevent one from getting COVID, and maybe that's the best prevention. But next slide. Unfortunately, as far as treatment of the fibrosis, we don't have one that can hasten the resolution or ensure that the fibrotic fibers will actually be absorbed. Next slide. We are, if you look at the clinical trials there, and there's several, they are looking for the magic formula, and we are waiting for the result. Next slide. Next slide. Okay, and there's some personally, I'm so happy that they are working on it. Maybe in the near future, they can find the solution among those patients with fibrosis already. Next slide. Particularly those with persistent fibrosis. Because the other option, and in particular, if next slide, if the fibrosis actually gets worse, okay, or the severe pneumonia left a very badly fibrotic lung, hindi makahinga, then lung transplantation is indicated. There is like a waiting period of at least a month to make sure that this is the fibrosis that really will get worse because you don't transplant subjects where the fibrosis is getting better. But that is an option among those severely and permanently scarred. Next slide. Hindi naman ganon si Ma'am Beck. Now, lastly, look at here the association of breathlessness on the left side and the fatigue rating below. So there is an interaction of the manifestations of long COVID. Now, the breathlessness is not really highly correlated with the lung function test or even the X-ray. Okay. So there must be something causing the breathlessness. Even the O2 saturation, as mentioned by Ma'am Beck, it doesn't necessarily mean that pag breathless siya, ibig sabihin mababa na yung oxygen niya. The oxygen can still be good. So there must be something there. And the clue here comes when correlated with fatigue. The higher the fatigue index, tumataas yung breathlessness. And fatigue is not really affecting the lung. It's something else. But, you know, if you have breathlessness and fatigue together, it goes up. Worse if you have also post-traumatic stress symptoms. Post-traumatic stress is something psychological. Naalala ng pasyente, probably almost died or something, very traumatic. And if you add that, look, the breathlessness score goes up. So if we manage these patients with long COVID manifestation, in particular, the pulmonary manifestation as shown here, we probably have to address also the psychological aspect, the post-traumatic stress symptoms, because it worsens the feeling of breathlessness. So, and my last slide is as we you know, go on and try to find therapeutic measures, we should probably address the other components of the respiratory symptoms. It's not just antibiotic, it's not just steroid, but how the symptoms of the lung interplay with the symptoms from the other organ system, the psyche, for example. Put them in a group, maybe it's better. And we hope that someday soon we can find a better management for this. Thank you very much.
Thank you so much, Dr. Roa, for that very enlightening discussion about post-COVID-19 lung problems and management. So still we have that question in mind, but in Doc, can pulmonary or can pulmonary long COVID be prevented? So we have questions right now on our Facebook Live and of course to our Q&A Zoom room. But still, we will have one more speaker for this afternoon. And to further enrich the discussion on today's long COVID webinar, we also welcome the presence of Dr. Veeda Michelle Ancalan as our resource speaker. And Dr. Anlacan is a neurology specialist and an associate professor in the Department of Neurosciences at the UP College of Medicine. And she is also the head of the Philippine General Hospital Center for Memory and Cognition. To add, Dr. Anlacan is currently an active neurology consultant in the Department of Neurosciences at the Philippine General Hospital, or PGH, and the Department of Neurology, Institute of Neurosciences at the Medical City, and the Section of Neurology, Department of Medicine, and Cardinal Santos Medical Center. Today, Dr. Anlacan will discuss dealing with the long-term effects of COVID-19 on the brain. And for us to further understand how post-COVID symptoms affect our brain, let us all welcome Dr. Veeda Michelle Anlacan. Doc.
Thank you. If I may be allowed to share. Are you able to see my slides?
Very clear, Doctor. Thank you.
Okay. Good afternoon po sa inyong lahat on a rainy afternoon. I hope we will learn something today. This is a tough act to follow after Dr. Solante, Ma'am Beck, and also Dr. Roa. So I will discuss the neurologic complications of COVID, but I will focus on the brain itself. When COVID started, we really thought that it loved the brain. And that's why we did a systematic review and we tried to find out the neurological manifestations of COVID, no? Because the focus was really on the lungs since it's a respiratory virus. But through this systematic review, we were able to prove that indeed there were a lot of neurologic manifestations of COVID. And through a nationwide trial, data po natin ito sa Pilipinas. Now, this is one of the largest published trials from the Philippines. No, almost 11,000 patients, comprising 37 sites nationwide. No? So we gathered up the data of these patients and then we tried to find out if they had neurological manifestations. And indeed, a lot of them presented with many neurologic problems. And when we looked at those with neurologic problems, what we found out was that their mortality was higher and they had an increased risk of having respiratory failure and also increased risk of being admitted to the ICU. But what were the top neurologic problems that actually kept neurologists busy? It was encephalopathy, stroke, and seizures. So yan po talaga yung top 3. It didn't surprise us because this was really what we were seeing on a day-to-day basis since the pandemic started. But what saddens us is that this virus really had a propensity to stay in the brain, damage it, and cause sequelae. And we think that this is really primarily responsible for what we call the long COVID. And it really took some time. Dr. Solante discussed earlier that the definition of a long COVID was only published late 2021, almost over a year ago. So, and in this definition, I can summarize it into this long COVID syndromes, a lot of which involve neurologic manifestations. So I think the first one is really exercise intolerance. No? And a lot of long COVID sufferers will tell you this. No? Every little movement requires a lot of effort, just as Mom Beck was sharing earlier. No? The exertional dyspnea is really palpable, and also the fatigue. Some of my patients also have palpitations. No, initially they were dismissed as just nervousness, but more intensive workup shows that it's really beyond palpitations. Some of them have what we call postural orthostatic tachycardia syndrome. Some cannot even get up because their heart rate goes up. They get dizzy, or some of them get hypotension, sudden drop in blood pressure that causes them to have syncope, or what we call loss of consciousness. Some of them also have thermoregulation problems that may persist well beyond 2 or 3 months, qualifying them for long COVID. And of course, we had to deal with a lot of pain syndromes. When you have COVID, one of the top symptoms is really myalgia or muscle pains. No, it can be all over. It can be muscle and joint pains. But some have persistent muscle pains. And not only muscle pains, you can also have neuropathic pain. So ordinary sensations in the hands and feet, kahit haplos lang, will be very, very painful to them, elevating them to what we call allodynia, or neuropathic pain. And then they can have paresthesia, described usually in Filipino as pamamanhid, parang nangingimi. So those are the usual terms that are used to describe these symptoms of nerve damage. And then they can have persistent headache or persistent ringing of the ears. So those are also common. But the most distressing for neurologists and patients are the cognition, mood, and sleep disorders that accompany long COVID. For some, it may be in the form of brain fog. Brain fog is just a general term that we use to describe cognitive impairment. And for senior citizens, sometimes it's really more than cognitive impairment. It's already dementia, for that matter. But for the usual patient, they describe problems with their working memory, or what we call executive dysfunction, the ability to carry out daily tasks. But some complain of anxiety and depression, agitation, and even psychosis. It's very difficult to treat anxiety and depression just by self-help apps, or guidance from family and friends, although that is important. Professional help is more important because we don't know how serious it is. No? So mental health really matters, and I cannot downplay. I cannot say na you can take this for granted. This is really, really something serious, and it warrants attention. Let's go back and check some of the neurological and neuropsychiatric trials that were published. No? So meta-analysis give us very strong evidence of mid and long-term neurological and neuropsychiatric manifestations of the post-COVID syndrome. And of course, topping the list is brain fog and fatigue. Talagang sila yung very, very persistent and very, very worrisome. And it was consistent over several publications, with the most frequently reported being fatigue, difficulty in breathing, loss of memory and concentration, and even sleep disorders. Nasisira po talaga yung sleep patterns, no, after COVID. And among survivors in large trials, so these are analysis of just their data of people who seek help in healthcare. 59% of patients had neurocognitive impairment. So that's more than half. So it's really the top long COVID manifestation. So, and the rates are very high for when screening for anxiety, depression, and even post-traumatic stress disorder. And for the elderly, I think I have to highlight also delirium. And those patients who had delirium, or yung parang na they had fluctuations in cognition during the time that they were admitted. They had hallucinations or whatnot. So these are the patients that you have to follow up with because they are highly likely to have neuropsychiatric symptoms and possibly dementia later on. So this makes you think, why is this happening? What does COVID actually do? So I know this picture is quite complicated, but I can simplify it. Basically, when it is in our bloodstream, it induces a lot of inflammation. So it's this inflammation that causes what we call yung mga thrombus formation. That's why you have your strokes. Either it's an infarct or a bleed, and you also have your venous thrombosis, not just in the brain, but also in the legs, in the lungs. So you have all those things, and it triggers inflammatory cascades. So lalong nagkakaroon ng inflammation around the brain. It triggers our microglia. So these are neurons in our brain and triggering what we call the cytokine storm. You often hear this, but what does it really mean for us? No? This environment that is full of inflammatory factors is actually the ingredients for dementia. So this is also what we see in brains of patients with Alzheimer's disease, with vascular dementia, also with neuropsychiatric symptoms like attention deficits, depression, psychosis. No? So there is a lot of alteration of neurotransmission and also neuronal cell damage. So it gives you something to the form of an accelerated dementia. So it is this pathophysiology that actually made the Alzheimer's Disease International call for an emergency because they feel that this COVID pandemic will trigger future waves of dementia. We in the dementia world are actually prepared to have a lot more patients coming on in the next few decades just because a lot of people are aging. But we were totally unprepared for a pandemic that could actually accelerate the development of dementia among persons who get infected, and more so the senior citizens. So you might be saying, baka sa drawing lang yan or sa pathophysiology lang yan. Do we have real world data on this? And do we have data from the Philippines? So yes, we do. So we actually have this clinical trial halfway through already in BGH. We recruited patients who survived moderate to severe COVID, and we tried to get their blood. We're trying to analyze what part of their genes made them survive the COVID, what made them resilient, or what made them develop the other sequelae. We are also following them up for long COVID. But more importantly, 3 weeks after discharge, we did an MRI of their brains, and we also tested them. We did some neuropsychiatric tests on them. We did parang IQ tests on them. So we wanted to find out if there really was damage. Remember, these patients were not even referred to neurology. They did not show any signs of stroke, or they did not have any cognitive impairment on discharge. But what was surprising was that their initial MRI done within 3 weeks from discharge showed a lot of strokes. So there were either bleeds or infarcts, and in several areas of the brain. So they were not symptomatic, they were not complaining of anything. But we think that they should be followed up because this was really surprising data for us. So what will you do if you suspect that you have long COVID? First of all, please stay calm. The long COVID does not mean you will develop dementia. There are a lot of things that you can do to try and prevent it or try to get help. First of all is to make a list of all your symptoms and try to be really objective about it. No? Try to compare yourself before and now. A good measure will be 3 years ago because that was the time before the pandemic. Remember, marami na pong panggulo, no? Kasi there you can have depression and anxiety because of the lockdown, because of differences in our lifestyle, because of life circumstances. iba yung financial capability ngayon or work circumstances or even COVID itself. No? So you have to compare yourself like 3 years ago and now and try to make a list of symptoms which you think are really attributable to COVID. And then try to schedule for a checkup and be ready for some workup. The reason a basic checkup is necessary is because we don't also want to neglect other more obvious problems. So, but what are really alarming? So, what are the serious warning signs of a cognitive impairment? Of course, a memory loss that disrupts your daily life, challenges in planning or solving problems, or completing familiar tasks, whether at home, at work, or even when you're doing your hobbies. When you have your confusion already with your time and place, when you have trouble understanding images or spatial relationships, if you have problems speaking or writing or putting your thoughts into writing, or you have problems retracing your steps. And so basically, these are things that you do to make yourself independent. So if you lose this functional independence, so these are red flags. For example, you have trouble living alone, or it's hard for you to manage really daily activities, especially handling money, keeping track of your medications, traveling from one place to another, using your cell phone, your appliances, gadgets, shopping for supplies, or keeping your appointments and dates. Of course, these were not new. These were actually guidelines that we adapted from taking care of persons with dementia. So, aside from doing the checkup and being ready for diagnostics, I know that you are very inquisitive as to what you can do on your own. So you have to take care of your whole body. So not just the brain, not just the lungs, but your whole body after a COVID experience. So of course, it is prudent to eat right. And what is good for the heart is also good for your brain. The more colorful, the better. If your plate is more than half of vegetables and fruits, I'd be happy. So not only do you improve your cognitive risk, your cognitive processes, but you also try to prevent dementia down the line. And for those who are senior citizens, the same prevention rules for dementia are the same for lingering long COVID. So you try to address your hearing loss, try not to hit your head, manage your hypertension, try not to drink alcohol, manage your weight, don't smoke, get depression treated, avoid social isolation, avoid physical inactivity, control diabetes. Yung physical inactivity might be a tall order kasi for those people who have problems with breathing. But there are always ways to go around this. You might need guidance from your doctor. So as to your cognitive impairment, you should expand your what we call cognitive reserve. No? Cognitive reserve is when our neurons try to connect with each other. So this neuronal communication, this is a network that is very, very important, not only in the context of COVID, but also when we age. Because these networks, eventually, when we get older, of course, they will fail us. But if you have a very extensive network, then it is less likely to fail. So how do you grow your cognitive reserve? Of course, you have to be very active, no? So, and you have to have lifelong learning. You have to embrace that. You have to be always marites, no? You have to have hobbies and you have to be updated as to what's happening, not just in your environment, but also within your family and in your workplace. And as to those who are not able to do physical activities, like this is from our organization, we tried to share this online during the pandemic. No? So we made several exercises. You can just be lying down. You can be sitting kasi kung hingal ka pa and sitting is all that you can do, that's fine. As long as you try to move. No? Now, if these are still impossible for you to do, a little bit of stretching is also helpful because even studies in dementia prevention say that if you're unable to do yung mga high-intensity interval exercises or strength training, even stretching is preventive of dementia. And you can also try apps. There are a lot of free apps that are available. This is one of the app developers that our organization partnered with. It's a UK company, but we tried to make Filipino categories, no, to make it more fun for our Filipino elderlies para hindi sila bored sa bahay and hindi lang sila nakatutok sa TV watching and swallowing everything that spews out of the TV, no. So this is more interactive and somehow it practices the remote memory. So it's also a game that you can play with your family. And then for those who are taking care of elderly persons, you have to take care not only of yourself, but also of the elderly. So we have these things, they're free to download and free to share. So these are what we call eye support. No? So a guide on how to take care of persons with cognitive impairment and dementia. So at the end of the day, what do we want to do? Of course, you want to prevent it by vaccination and boosters. And I think we've come a long way. I have a publication wherein our findings say that of the less than 50 who were admitted for COVID, less than 50 persons with dementia who were admitted for COVID in the first year of the pandemic, and we did not have vaccines at the time, the mortality rate was more than 50%. So ganun po kataas. We are nowhere near that number now, and the difference is only because of vaccination. So this is something that we can't take for granted. And of course, the proper use of masks. No, I don't know if the numbers are true na mababa yung COVID because you can know from your families and friends that there are a lot. No, they probably don't swab anymore. They just do rapid antigen. But I think we still have to be careful, and I will still be keeping my mask on. And dealing with long COVID, how do you deal with it? Of course, knowledge is power. No? The more you know, the more you will be empowered, the more you will ask better questions to your physicians, and the more you can address your symptoms. And you have to have cognitive stimulation. Hindi pwedeng nakakulong lang palagi sa bahay, tulog ng tulog. So you try to get up, you try to do something worthwhile. If you're not physically able to do it, you try to go online. There's a wealth of things that are available for you online. Try to exercise to the best of your capacity and always go for a checkup. When in doubt, go for a checkup. I specifically left out the psychiatric matters because they're very heavy. And I really feel that consultation is necessary. And I think the pandemic made the psychiatrists and mental health specialists more accessible to us. No? Kasi accessible na sila online. No? So anytime, anywhere, you don't need to even go to the hospital. In the comfort of your room, you can consult them. So these are things that are highly treatable. So I hope that you find the help that you actually need. So yeah, I think that's the end of my talk. Thank you for listening, and I'll be ready for the questions later.
Thank you so much, Dr. Anlacan, for the enriching discussion on dealing with long-term effects of COVID-19 in the brain. I know some of you, ang ilan din po sa atin, have written down their concerns, their questions for these discussions. And thank you to all of our speakers for sharing their enlightening and informative talks. And with this, let's proceed to the open forum. Once again, we'll be opening the question and answer box. And so to everyone who's still with us, we highly encourage you to send in your questions via the Q&A feature kung kayo po ay nasa Zoom, and in the comment section if you're joining via Facebook Live. And we have all our speakers ngayong pong hapon. It's a rainy afternoon, I was told, but that wouldn't stop us from sharing and answering all of our viewers' concern. We will start off with Mama Rebecca. We have one question here. How did your family members help you during the difficult period. As we know, no, it's a long COVID. We've seen the photos, marami pong preparations, and of course, a support. Paano po nakatulong ang family on your recovery, ma'am?
Well, yung family ko, of course, unang-una my daughter, she had to well, she had to stop working to take care of me. Sorry. So, and of course, everybody was on board. Not hindi lang yung immediate family ko, but even yung, hindi lang nuclear family ko, but even my extended family, other families, yung spiritual family, friends who I consider family. So, they took care of me directly, and they gave me encouraging words, nagpapadala ng ayuda. Yung mga texts or messages, nakakatulong siya. So, it helps a lot. So, yun. Sorry, bumalik lahat.
Thank you so much, Ma'am Rebecca. And it's really important, no? One of which that really help the long COVID patients are really the emotional support that up until that course, no, nandyan pa rin ang support. Thank you so much, ma'am. We have one question for Dr. Rontgene. Does vaccination booster shot lessen your risk on getting long COVID po?
Yeah. Thank you for that question. No? So there were two data to support that, no. But one of the largest data was done in UK. The observation then was for those who had vaccine and received booster and then had breakthrough infection, they have lower risk of long COVID compared to those who did not receive the vaccine. So which means that the vaccine reduced the risk of long COVID. Then there was this other population wherein after they have long COVID and then they were vaccinated. So which means that they already completed the primary vaccine, they developed long COVID, and they received the booster. It was noted that the duration of long COVID was a bit shorter compared to those who did not have the booster. No? So I think these are some good data that vaccine really help a lot, not only in preventing the infection, but can also reduce the risk of long COVID.
Thank you, Doc. Doc, do you still advise the same question I would ask Dr. Roa and Dr. Anlacan? Do you still advise that once you got COVID, kailan po yung duration that you can get the next? Could be the booster, or for those who are unvaccinated, does it still apply the 2-week or the 1-month window? Doc Rontgene to answer it first. Thank you, Doc.
Okay. Now our guideline is regardless of what your symptom is. If you have previous infection, the earliest is really 2 weeks now. So whether it's 2 weeks after the acute infection, and after 2 weeks you still don't know if you have long COVID. No? So that's where one of that study was observed that when they were given the booster, their risk of the long COVID is really lower compared to those who did not receive the booster. So in terms of timing, 2 weeks after the acute infection, that's the minimum number of days that you can receive the vaccine.
Thank you, Doc. Dr. Roa, what about for patients with asthma or those who are infected with allergies? Ano po ang ating duration also with the vaccine? It's the same thing din po ba?
Well, the vaccine can be given anytime in those conditions, subject to the information given by Jean. And siguro kung nag-vaccine din siya before, mga 3 months later at least. And of course, in this situation of the COVID pandemic, kung may asthma ka, i-control mo. don't allow your asthma to be continuously symptomatic tapos babaksin ka. We have enough medication anyway to control asthma and most of the like allergic rhinitis conditions.
Thank you so much, Dr. Roa. What about for Dr. Anlacan? How about to patients who are suffering from anxiety? Some of them minsan nagkakaroon din ng reaction like bronchial asthma. When do you advise getting the vaccine or maybe the booster once they get COVID po?
Sorry, that question's for me. Sure ka, hindi kay Dr. Roa. So,
Yeah, I think yun na yung sagot din kanina.
respiratory.
Still pa rin.
Pero yung isang question sa neuro talaga yung si Michelle hindi na tinouch yung psychiatric, pero that last slide ko yung graph ko, it's really compelling. The disease niya worsened among those na may yung concomitant post-traumatic manifestation. So maybe it's not really organic all the time. There probably is an organic thing, but there has to be something that is related to the psychological trauma or the fatigue that is very non-specific. If there were none of this, the dyspnea would have been less.
But sir, you will agree with me that when we refer to psych, they really help out a lot, no? Whether it's really what we call organic or not, no? They are helped not only by medication but also by the mere fact that they have consultation with the psychiatrist. No, nako-coach sila into strengthening their psychological reserves. I think there are a lot of questions for me on the chat box.
Yes, I got it right now, Doctor. Thank you so much. For Doc Roa, is the exercise intolerance in long COVID permanent?
In most cases, no. In parallel with the structural improvement, you follow the imaging, CT scan or X-ray, where the rule is improvement. Merong hindi tuluyang nag-improve, pero karamihan nag-improve. And in functional tests, na nag-improve din yan eh. We have the parameter FEV1, mga ganun, nag-improve din yan in most cases. The exercise tolerance generally also improves with it. Now, having said that, meron talaga yung nag-improve na, ganun pa rin yung exercise tolerance niya. So, I think there's something there that we have to attack in parallel, and that probably includes the psychiatric part.
Thank you, Doc. A question for Dr. Veeda. Is paranoia part of long COVID symptoms? Example daw po, being scared of reinfection or infecting other people.
Pag pandemic talagang heightened yung paranoia natin, ano. Of course, if it already affects your daily life and it is irritating to your family, you have to consult, no, if it's already starting to affect others and your way of life.
Thank you po, ma'am. We have another question for Dr. Rontgene. Is panthosmia a part of long COVID? Because I have been smelling weird stuff for almost 2 years already. Para daw po amoy sunog. Oh, Doktora, sorry po.
I think it's mine.
Sige po.
So yes, that's true, no? Because COVID damages the olfactory epithelium and also the olfactory nerve, no? That's why a lot of patients report having no sense of smell. But when it does try to repair, there is what we call faulty repair. So it's very possible for you to iba yung stimulus pero iba yung nasa smell mo. And usually, the odor is not pleasant. So that's a very sad sequelae of COVID, but yes, it could happen.
Ang na-mention niyo daw, Doktora, amoy sunog. Parang burnt smell.
However, you have to consult with your neurologist because that could also be a serious symptom of another disease, no? Kasi baka i-attribute lang natin sa COVID pero there's another problem there. So you need to consult a neurologist. But faulty neuronal repair is very common. I think a lot of patients have Bell's palsy Tapos pag nag-repair, 'di ba, hindi siya perfect. That's why ngiwi pa rin yung face, or minsan some patients have what we call hemifacial spasm, yung gumaganon yung half ng face nila because of faulty repair after Bell's palsy.
Thank you so much, Doctora. We have another one for Dr. Roa. Does the diagnosis of post-COVID-19 condition require the presence of all three symptom clusters, fatigue, cognitive, and respiratory problems? Or okay lang daw po just at least one of the three?
Yeah, most of the time, multiple yan. Pero meron ding isa na prominent. Ang requirement lang dyan, nagka-COVID siya.
And that it lasts 2 to 3 months
Yeah.
after the COVID, and it's persistent, no, not pre-existing before the COVID.
Thank you so much, doctors. One question for Ma'am Rebecca. Ma'am, how did you know daw po that your symptoms are part of the long COVID?
Well, I've been in constant touch with my doctors during hospitalization and after hospitalization. So I think I'm a diagnosed long COVID.
So it's really important to get back to your doctor every time. And thank you so much, ma'am. Another question here we got from our Facebook Live. I think this is for all our doctors. Is there a tool or self-assessment tool daw po na available in the Philippines to know if you have long COVID? I think our doctors have put out the symptoms, but meron po ba tayo inilabas na list so people can identify this also? To better answer first, Doc.
Alam mo, Natalie, sorry.
Yes,
Even in North America and in Europe, they're still trying to validate these, no? Kasi sobrang daming listahan ng long COVID symptoms and you don't know what to include or not. And the problem with surveys and screening tools is that it can't be too long and it can't be too short. So there are a lot of things being validated. We don't have a screening tool. That's why I advocated that you have to write down your specific symptoms, and so that you can report it to your doctor.
Thank you po. Okay, I think Doc Jimmy has a question in our question bank. Doc, thank you so much. What are the characteristics of an effective and helpful long COVID support group based on the experiences of our speakers po this afternoon? Doc Roa, if you may answer. Thank you po.
Well, I have no experience, but I am really interested in our patients here, kasi I'm sure maraming long COVID, to actually do that, because it creates a support system that can go beyond just the medication. And well, to start it, you need champions. Kaya kailangan, katulad ni Ma'am Beck, and the group can actually bankroll it at the start. And then this support system, this group, should be in touch with a multidisciplinary team of doctors. Doctors who provide the expertise needed to analyze a patient. Kasi minsan hindi klaro if one specialty lang. And there could be overlapping, overarching situations, and in the multidisciplinary discussion with the patient through the group, we can have a better advice and probably better outcome.
Okay.
Thank you so much. Yes po, Ma'am Bex.
No, I mean, being a long COVID patient, I think I feel that each long COVID patient needs really support because it's a difficult journey we're going through. So I think also, aside from what Dr. Roa said, diba, there could be a peer group of long COVID patients supporting each other. I mean, doing activities together, diba? Kasi we're kinda ostracized or sidelined or marginalized, because a lot of people think that long COVID patients are just inarte or something, diba? So, I mean, the support group has to be composed of people who are competent, knowledgeable, and compassionate. That's my take. Thank you.
Thank you po, ma'am. For our next question, I think I saw one question from our Q&A box. How long will one recover from the post-COVID MRI brain findings? And can you hasten the recovery daw po?
Well, definitely recovery is possible, no? Especially if you're less than 60 years old and there's no other problem in the brain. If they are just incidental strokes because of COVID, you should be able to rebound without any further problems. No? But for the more senior citizens, those who already have what we call vascular burden in the brain, those who already have tiny strokes that are silent, or marami ng what we call yung mga areas na traffic sa brain nila, then of course, this is a different matter. No? There's also something in the chat box that's a question that's asking kung 80 years old, paano. So all the more they need to be checked because there are other factors that may mimic long COVID and cognitive impairment in this age group. Remember, as we get older, our risk for dementia increases also. So this is a double whammy for those who are older persons and those who had COVID.
Thank you, Doctora. Another one is asking, our participant is asking, are the changes in the lungs irreversible when diagnosed with long COVID? I think we have shown a study a while ago.
Yeah, the short answer is most of the time they are reversible or actually they get better. Hindi lang all.
Thank you, Doc. Question for Dr. Veeda. We have a concern here. Do patients with neurologic conditions prior to getting infected with COVID more at risk of getting long COVID effects on the brain?
Yes.
Mhm.
That's a big yes. Because meron ng insult, tapos nadagdagan pa.
Thank you so much, Ma'am. A question, I think this is a concern or a comment from Sir Ruel, one of our participants. Yes, Miss Rebecca, we look normal, and when you tell what you're experiencing, it's also painful to hear from your loved ones na arte lang. And it's really not arte lang. So, ayan po. We are getting also support from our participants who experience the same thing. And okay, maybe we'll put in another question for all of our doctors. Siya daw po ay isang occupational health nurse, currently working for a company, and unfortunately, we do not have a physician in the clinic. Ang kanya pong question I would like to ask, especially for patients who are under home care or home quarantine due to mild symptoms and or testing positive in home test kits or antigen test, how do we identify the incidence of long COVID for individuals, and how do we do the referral for proper diagnosis? I think one of our speakers mentioned 4 months na positive sa RT-PCR.
Maybe Jean?
Yes, sir. Yeah, for those who are in home care, okay, and if you you really have to have consultation with doctors, no? And it's important for you that with that consultation after recovery. In fact, in our patients in here in San Lazaro and in some in my private patients, I usually have them followed up every 2 weeks for the next 2 months, even if they're normal, no? Because some of them may have the long COVID 30 days after the recovery, or sometimes 2 months after. So any symptom that will occur within that 3 months to 4 months period after the acute infection, then that can still be part of the long COVID. So that means that it entails. So yung situation ng ni kasi walang doctor. So it's more of really hooking that those patients with doctors really to have a very accurate observation and evaluation.
Thank you so much, Doc. Jean. I think this is from one of our participants as well. What can family members do to support long COVID patients? I think Ma'am Rebecca answered it already, but when it comes to more than the emotional support, ano pa po ang pwedeng maitulong no, ng family members aside of course from having a long COVID support group?
That question is for me. Okay, what
Yes.
else can the family? Well, many things. Actually, not only emotional, but the physical presence, diba? Understanding what you're going through, diba? Especially yung nuclear family mo. But even your nuclear family needs support, diba? Because mahirap yung may long COVID patients, so they have to adjust, diba? Marami ring adjustments. You disturb their regular schedule. So even your nuclear family needs support from the extended family. And like I think I've been blessed because even friends, talagang, I mean, I felt so much love when I had long COVID and I had COVID, Parang there really was an outpouring of love and concern. So, and it really helped, diba? The concern, the care, and the understanding. So, I mean, well, for some people, they need probably financial support, ayuda, diba? So, I think it's a case-to-case basis and facilitation for referrals, for doctors. So, it's a case-to-case basis.
Yeah. Natalie, can I add to that?
Go ahead, Doc.
Helping them with their medication. Kasi yung iba may brain fog. Iba ka magkamali yung dose ng gamot. Lalo na kung may concurrent na several comorbidities. So they really need somebody with them. Among other reasons yun sinabi ko.
Thank you, Dr. Roa. Another question here is about the vaccine. Nagtatanong po ang ating attendee, should I get another booster? Ang kanyang second booster was 4 months ago. And what kind of booster shot should we get now for the new variants? Singapore offers a certain type of brand, the Moderna bivalent booster. Yun daw po ang meron po sa Singapore.
Okay, so we'll have to wait for the bivalent Omicron booster, no? So most likely, if that will come, there will be 10 million doses that are being ordered now for Moderna. We don't know yet for the Pfizer vaccine. We're waiting for some of the technicalities in terms of the approval and release of this vaccine. Most likely first quarter of next year. But again, since it's only around 10 million, it will be prioritization. And who are the priorities? These are the vulnerable population. So anybody who has received the first booster can have their second booster, the bivalent vaccine. For those who have received the second booster, particularly the immunocompromised, the 50 years old and above, then their third booster can be the bivalent vaccine.
Thank you, Doc. We have here question for okay. Medyo ayan. Yeah, a critical COVID survivor and was considered a long COVID patient with several post-COVID syndromes until now. Nakapagpa-vaccine na din daw po siya. But I did not had any booster yet because I developed a pimple-like rashes at my back and on my head after the 2 jabs. I also had hair loss on my second dose. Our participant is asking, would you still recommend the booster shot for me?
Yes, it's important. No? Those manifestations you have are not contraindications of receiving another dose of the vaccine. Okay, in fact, the only contraindication of receiving another dose are those who have severe allergic reaction or anaphylactic reaction to the vaccine. But again, you can also have other options for that. Like, for example, if you have severe allergic reaction to an mRNA, then the other option could be a viral vector or the inactivated vaccine. So we should find ways now on making vaccines available, and at the same time, as much as possible, you should be getting the vaccines. Particularly, you are a vulnerable and high-risk patient.
Thank you, Doc. We have another question for Dr. Veeda. Are patients able to completely recover their cognitive functions after the long COVID?
Yes, definitely, especially for those who are relatively young.
And another question, how often daw po, Doktora, have you seen patients with pantosmia?
A
A lot. Ayun. Maybe I would be sharing the same thing, ano? I just had it not too long ago. But iba naman yung sa akin, metallic taste naman, Doktora. So not just the scent, but the taste. So right now, I'm really trying, just like a baby, no, trying to one by one recognize the different tastes that I lost, and I know for myself that it's really really common. Okay.
Persistent siya. Persistent siya, not only during COVID. Kasi sometimes people mistake it. It's their actual medication that has the metallic taste, either the antiviral or the antibiotic that they have to take during that time. But if it's persistent, it's likely COVID-related.
Thank you, Doc. Ganun po talaga pala, no? Pag kahit matagal na din. A question for all of our participants, all of our speakers. Is there a marker daw po to say that the patients have finally recovered from long COVID?
No, none.
Sa akin, when they go back to their usual, that is the marker that we are good.
Ayun, thank you po. What about po kay Doc Roa?
Walang particular marker na, good ka na, green ka na. Yeah.
Thank you po. So right now, I can see here if all of our speakers are available for consultation. So marami pa rin pong nagtatanong from, I think this is from our Facebook live, no? And maybe, okay, meron pa rin po tayong question here. Is it possible to have just one post-side effect of anxiety/depression after COVID, even if you do not have other symptoms of long COVID? Parang, Doktora, ano lang, ito pong anxiety and depression lang.
Yes, why not? It's very possible kasi na-trigger siya.
Thank you so much. Ma'am Bex, meron na rin pong nagtatanong the details of the long COVID support group. Baka mag-start na ang group po.
We don't have the details yet, but we'll get in touch with you if you there's a question in the registration if you're interested to join the support group, and it's also in the evaluation form, so we'll get in touch with you.
Thank you so much po, ma'am. And okay, there you have it. I know there are a lot of questions pa rin po on our Facebook Live, but it's about time. Nagpapasalamat po tayo sa lahat po na ating speakers this afternoon. Thank you so much, Ma'am Bex Galvez Tan, Dr. Solante, Dr. Roa, and Dr. Anlacan for the very rich and informative discussion. But before you go, I would like to award you a certificate of appreciation on behalf of HFI. Health Futures Foundation Incorporated awards a certificate of appreciation to Maria Rebecca M. Galvez Tan for her enriching talk on My Long COVID Story in Is Long COVID Real? Post-COVID Conditions and Management webinar on the 4th of November 2022 via Zoom, given this 4th day of November 2022. So thank you so much, ma'am. We'll be taking a photo for this. And the next one po, Health Futures Foundation Incorporated awards a certificate of appreciation to Dr. Rontgene Solante for his enriching talk on long COVID and its aftermath in Is Long COVID Real? Post-COVID Conditions and Management webinar on the 4th of November 2022 via Zoom, given this 4th day of November.
Thank you.
And the next one po, Health Futures Foundation Incorporated awards a certificate of appreciation to Dr. Camilo Roa for his enriching talk on post-COVID-19 lung problems and management. And this is a Long COVID Real, Post-COVID Conditions and Management webinar on November 4, 2022 via Zoom, signed on this day. Thank you so much.
Thank you.
And finally po, Health Futures Foundation Incorporated awards a certificate of appreciation to Dr. Veeda Anlacan for her enriching talk on dealing with long-term effects of COVID-19 on the brain in Is Long COVID Real? Post-COVID Conditions and Management webinar on the 4th of November 2022 via Zoom, given this 4th day of November 2022. Thank you so much.
Salamat.
And as we approach the end of today's webinar, HFI would like to thank Ma'am Rebecca Galvez Tan, Dr. Solante, Dr. Roa, and Dr. Anlacan once again for sharing the valuable insights on long COVID and its effects on our body. Ayan, looking forward daw po ang ating mga participants for part 2. And of course, our utmost gratitude and appreciation goes to all our webinar attendees who joined us today as we learn new knowledge that is timely and relevant to our objective to achieve holistic health and wellness. So next up, help us improve our future webinars and events by answering our short evaluation form. At yan po is flashed on your screen. Or you may type in bit.ly/long COVID eval. That's EVAL. You can scan the QR code on the screen. The link was also sent in the chat box. And please be reminded that the deadline for answering the evaluation form is only until the 5th of November 2022 at 2:30 p.m. only. Again, I would like to remind everyone that we will be sending certificates to our Zoom participants who stayed all throughout the webinar and accomplished the evaluation form. And lastly, help us reach more people by following us on our social media platforms. As you can see on your screens, you may visit our website at www.healthfuturesfoundation.com. Pwede nyo rin pong i-like or i-follow po ang pages po natin on Facebook, facebook.com/healthfutures for timely health tips and for the latest news and updates on HFI's events and projects. And our Facebook. Ang Facebook din po, facebook.com/alaga.ka for news and updates on HFI's banner project, Alay sa Ginhawa at Kalusugan or Alaga Ka. You may also follow us on Instagram and Twitter. That's at Health Futures. Or subscribe to our YouTube channel, Health Futures Foundation Incorporated. Follow our LinkedIn page. Ayan po, linkedin.com/company/Health Futures. And once again, thank you for staying until the end of the program, and we hope you learned a lot from our speakers. Again, this has been Nurse Natalie, your facilitator for today's webinar, Is Long COVID Real? Have a good day and see you in our next events.